All right, let's unpack this. You've got a stack of research, articles, maybe your own notes, and you're looking to cut straight to the good stuff, those surprising facts, the aha moments that truly make you feel well-informed. You've definitely landed in the right place. Today, we're taking a deep dive into two really cutting-edge therapies, Triglyceride and Plozasiran. These are fundamentally transforming how we approach severe hypertriglyceridemia, or SHTG, and also a rare genetic condition known as familial chylomicronemia syndrome, or FCS.
Yeah. And our mission for this deep dive is, well, to distill the most important nuggets of insight from your sources on these two RNA-targeted therapies. We'll be comparing their efficacy, their safety profiles, and those key practical differences. The goal is ensuring you walk away with a truly comprehensive understanding of this really rapidly evolving field.
And just to set the stage quickly, for anyone needing a refresher, SHTG. That's diagnosed when your fasting triglyceride levels hit 500 milli-GDL or higher. And, as many of you know, the most dangerous consequence really is the threat of acute pancreatitis, which is a painful, often debilitating, and potentially life-threatening inflammation of the pancreas.
That's exactly right. And for far too long, traditional therapies have only offered pretty modest reductions in these dangerously high levels. They often fall short of adequately mitigating that critical risk of acute pancreatitis. This has left a significant unmet need for, well, truly effective and durable solutions. And this is precisely where Triglyceride and Plozasiran step in. They're aiming to fill that crucial gap.
Okay, now here's where it really gets fascinating, I think. Both of these drugs, Triglyceride from Ionis Pharmaceuticals and Plozasiran from Arrowhead Pharmaceuticals, they represent a groundbreaking new generation of RNA-targeted therapies, specifically designed to tackle this challenge.
What's truly remarkable here is that both drugs work by strategically inhibiting the production of a specific protein, apolipoprotein C3. You can think of this protein like a brake on our body's ability to clear triglycerides from the blood. So by reducing ApoC3, we essentially take that foot off the brake, allowing fats to be processed and cleared much more effectively. And that lowers those dangerously high triglyceride levels.
That's a crucial target then. So while they're both aiming at the same protein, ApoC3, they have key distinction in how they achieve that inhibition right at the molecular level. Triglyceride, which is also known as Olezarsen, that's an antisense oligonucleotide, and ASO. Think of it like this. It's a tiny targeted molecular message sent directly to the cell's main blueprint factory, the nucleus. There, it interferes with the original messenger RNA instructions for making ApoC. It kind of stops those instructions from ever being fully transcribed.
Precisely. Plozasiran, on the other hand, is a small interfering RNA, or siRNA. So rather than acting at that blueprint stage in the nucleus, Plozasiran intervenes later. It waits until those ApoC3 messenger RNA instructions have already left the nucleus and are out on the, let's call it the assembly line in the cell's cytoplasm where proteins are actually built. It then intercepts and silences those instructions right there. Both mechanisms are incredibly precise, and they're delivered right to the liver where ApoC is mainly produced using a special delivery system called GalNAc. The subtle difference in when and where they act within the cell, well, it directly impacts their duration of action and, as we'll definitely get into, their dosing frequency.
That's a great way to visualize it, the blueprint versus the assembly line. Okay, so after understanding how these molecular marvels operate, microscopically, the critical question is, are they truly making a difference for real people? Let's peel back the layers on the clinical trial data. What's the impact? How effective are they really in bringing down those high triglycerides and preventing that agonizing acute pancreatitis?
Let's start with familial chylomicronemia syndrome, FCS. That's where we have the pivotal phase 3 data for both therapies available now. Okay, so for Triglyceride, the BALANCE study demonstrated a highly significant 57% placebo-adjusted triglyceride reduction at 12 months. But what's truly transformative for patients, I think, is the impact on acute pancreatitis events. The study showed a really dramatic decrease from 30% in the placebo group down to only 5% in treated patients.
Wow. An 83% relative risk reduction. That's undeniably impressive. For listeners maybe less familiar with clinical trial data, could you briefly explain what relative risk reduction really means in a practical sense for someone with FCS? What's the real-world impact?
Absolutely. That's a great point. An 83% relative risk reduction isn't just a statistic on a page. For a patient who's maybe experienced that excruciating pain, the ER visits, the constant fear of it happening again, recurrent acute pancreatitis, it's a huge shift. From living in constant anxiety to potentially regaining a normal, high-quality life, it represents a fundamental change in their prognosis. Moving from a high likelihood of future painful episodes to a significantly reduced risk. That's the real aha here, a profound improvement in their day-to-day
Yeah,
existence.
context really makes all the difference.
Okay.
Okay, now, how does Plozasiran stack up in FCS?
Well, in its Palisade study, Plozasiran achieved an approximate 61% to 63% placebo-adjusted triglyceride reduction. That was measured at 10 months. And strikingly similar to Tryngolza, it also showed an 83% reduction in the risk of acute pancreatitis events. The incidence there decreased from 20% in the placebo group to a mere 4% in the patients treated with Plozasiran.
So stepping back for just a moment, what's truly striking here, looking at these FCS results? Both drugs show remarkably similar, incredibly strong reductions in that pancreatitis risk.
Right.
It's almost uncanny, really.
It is indeed. And while Plozasiran appears to have a numerically greater triglyceride reduction in its specific FCS trial, it is vital, as you know, to remember these were not head-to-head trials. We should only say this once, but it's important. Direct comparisons between them must always be interpreted with caution because there are inherent differences in study design, maybe the patient populations enrolled in each trial. The key takeaway, though, is that both offer substantial, really clinically meaningful benefits in FCS.
Right, understood. So looking beyond FCS, which is, well, a rare condition, what about the broader severe hypertriglyceridemia population? That's where most patients fall, isn't it? For Tryngolza, we're eagerly awaiting phase 3 data from its CORE and CORE2 studies. That's anticipated in the third quarter of 2025, I believe.
That's the timeline, yes. And for Plozasiran, its Shasta-3 and Shasta-4 phase 3 studies, also in SHTG, have actually already completed enrollment. We're expecting top-line data from those around mid-2026. So this really raises an important question, doesn't it? How will these two powerful therapies ultimately compare in that much larger SHTG patient group once all that comprehensive data becomes available? The landscape could shift significantly then.
And beyond just the raw triglyceride numbers, you mentioned Plozasiran also has some, well, intriguing data from its earlier phase 2 studies, Shasta-2 and OMIWire, suggesting maybe additional benefits, something about LDL particle size shifting towards larger, maybe less atherogenic particles, and a modest increase in HDL.
Yes, that's a fascinating area. It does suggest Plozasiran's benefits may extend beyond just the direct triglyceride reduction. It could potentially improve the overall lipoprotein quality, which might have broader cardiovascular implications down the line. However, it's really important to frame this carefully right now. This isn't yet definitively linked to hard clinical outcomes, like a reduction in, say, heart attacks or strokes, ASCVD events. It's currently more of an interpretive extrapolation based on those biomarkers. It's certainly a compelling area for extensive future research to fully explore and validate.
Okay, so pulling all these different threads together,
Yeah.
what does this mean for the actual patient experience? Let's talk safety and dosing. Those are huge practical considerations when someone's looking at a long-term therapy for a chronic condition like this.
Absolutely. For Tryngolza, the common adverse reactions reported in the trials include things like injection site reactions, a decreased platelet count, and arthralgia, which is joint pain. Now, regarding that decreased platelet count, it's important to understand this is not the severe thrombocytopenia that was seen with some earlier drugs in this class. It indicates a much more refined safety profile, but patients will still need regular monitoring, blood tests to check those platelet levels.
Right. And on the other side, for Plozasiran, the most common side effects included things like abdominal pain, nasopharyngitis, basically symptoms like common cold and headache.
Yeah.
These were often reported at rates similar to what was seen in the placebo group.
Mhm.
And a significant distinction here for Plozasiran is that it's explicitly stated to be without platelet concerns. That seems like a notable point of differentiation.
It is. However, and this is important to balance that picture, Plozasiran has had some observations of worsening glycemic control. This seemed particularly noticeable with higher doses in patients who already had prediabetes or diabetes. Additionally, mild to moderate elevations in liver transaminases, those are enzymes that can indicate some liver stress or inflammation have been noted. So these definitely warrant careful monitoring in patients treated with Plozasiran. It suggests that perhaps certain patient profiles might be better suited for one drug over the other, or at least require different levels, maybe different frequencies of vigilance.
That's a really critical nuance, especially given the metabolic context of so many patients with high triglycerides.
Yeah.
Okay. Now let's talk about the really practical difference, the one that can profoundly impact adherence: dosing frequency. Triglyceride is administered once a month, right, as an 80 milligram subcutaneous injection.
Correct, once monthly. And what's truly fascinating here, and potentially a real game changer for patient convenience, is that Plozasiran is given much less frequently. It's a 25 milligram subcutaneous injection, but only once every 3 months. Quarterly dosing. This significantly less frequent dosing is a direct consequence of its siRNA mechanism, which allows for a more sustained effect within the body, hence less frequent administration needed.
From a patient perspective,
Yeah.
wow. That quarterly dosing for plozasiran could be a monumental difference. Just imagine what that means for someone managing a chronic condition, right? It's less disruption to their daily life, fewer reminders of their illness. It could be a significant psychological boost to sticking with a therapy long term. It effectively turns what could feel like a persistent medical burden into something more like a manageable, almost forgettable quarterly check-in. That seems like a massive leap in potential quality of life.
It really does highlight the potential impact of mechanism on patient experience. Finally, let's just quickly touch on the regulatory landscape and market positioning. Triglyceride, as we know, gained FDA approval for FCS back in December 2024. That gave it a crucial first-mover advantage in the U.S. market, specifically for this rare condition.
But plozasiran is hot on its heels. Its new drug application, the NDA for FCS, was filed by the end of 2024, and it has a PDUFA action date that's the FDA's target deadline for a decision set for November 18, 2025. So Triglyceride's first mover advantage in FCS might actually be quite temporary, with plozasiran potentially getting approval relatively soon.
Exactly. And if we connect this to the broader picture, once both drugs are potentially available, especially if plozasiran gets that FCS approval, you have to think patient preference for that remarkably less frequent quarterly dosing of plozasiran, combined maybe with its no platelet concerns profile, and those potential, though still exploratory, lipoprotein benefits. That whole package could really position it strongly in the market, especially as that crucial SHTG data matures for both therapies over the next couple of years.
So to try and synthesize everything we've explored today, Triglyceride and plozasiran, they represent clear, really significant advancements in treating severe hypertriglyceridemia and, maybe most crucially, preventing acute pancreatitis. Both are highly effective RNA-targeted therapies. Both significantly reduce apoC-3, and that leads to substantial triglyceride lowering, and as we've highlighted, that incredible 83% reduction in acute pancreatitis risk we saw in the FCS trials for both drugs.
Right. Their key distinctions, and where that real-world choice is likely going to come into play, lie in that dosing frequency. Plozasiran's quarterly regimen offering a significant convenience edge, potentially, and also in their nuanced safety profiles. We have Triglyceride noting the decreased platelet counts needing monitoring, and plozasiran having those observed glycemic and liver enzyme concerns that will also require careful monitoring, especially in certain patients.
And the landscape for both SHTG and FCS is definitely rapidly evolving. We've got more crucial phase 3 data coming down the pipeline from both therapies. That will undoubtedly give us an even clearer picture of their full potential and how they compare in the larger SHTG population.
Which really raises an important question for you, our listener, to consider as these powerful therapies become more widely available in the clinic.
Yeah.
How will that delicate balance between regulatory status, those nuanced safety profiles we discussed, and what might be paramount for many patient convenience? How will all that ultimately shape the real-world adoption and the prescribing patterns of these potentially game-changing new therapies in the years to come?